this session. Welcome, sir. Over to you.
Thank you very much, Navneet Singh ji. Dear trainees, if you really want to understand any subject in oncology, two ways. One is you look at the evolution, how we arrived at this. Like, how we started from radical mastectomy to modified to breast conservation to no ink at the margin to ALND to SLNB, targeted axillary, de-escalation, hypofraction. So if you read the evolution and the landmark articles, then you can understand what is the journey which took to arrive at today's standard of care. Because you must distinguish between standard of care and gold standard and what is acceptable evidence-based practice today. So to understand that, the best way is to study the landmark articles. But remember, what is written in the line and the article by the author is not what is important. What is written in between two lines. To do that, you need two great experts, and today we have Professor Dr. Dev and Rosina. And Professor Dev is the president of Association of Breast Surgeons of India, senior most surgical oncologist and president of IASO, and a great teacher. Also was a past head of department at AIMS. And Rosina is heading the breast services at Tata Medical Center in Kolkata. Great friend, great contributors in ABSI, great teachers. And they themselves have published innumerable papers. So today, the two experts will help you unlock what is in between the lines, the strength and weakness, and take-home message. To present today, we have DRND Surgical Oncology resident from Mahavir Cancer Sanstha, Patna, Bihar, Dr. Saumyta Mishra, who is going to present landmark papers and two papers which will be interpreted. Thank you very much and welcome to Rosina and Dev, and over to you, Saumyta.
Thank you, sir.
Thank you.
Good morning, sir. Today, this is the overview of breast cancer. I am presenting two recent articles published in the last 6 months. Breast cancer is the most common cancer, as we know, and it is categorized on the various subtypes based on the hormone receptor status, HER2 expression, and other molecular characteristics. And treatment is multimodality treatment. So, since breast cancer is the oldest disease and is most common disease, many trials have been published, started from the radical surgery to the minimal surgery, and now they are heading towards no surgery. So NACT 04 is the first trial, 1976, given by National Surgical Adjuvant Breast and Bowel Project Group. They have compared radical mastectomy to total mastectomy, and they have found equivalent good results, followed by 1981 Milan 1 trial. In 1985 NACT 06, both have compared the BCS is equivalent to mastectomy, followed by that NACT 13 in 1985, introduction of chemotherapy in the breast cancer treatment. They have compared CMF versus MF. For NACT 17 in 1993, introduced the role of BCS in the DCIS. Followed by that, in 1998, NACT 1, in use of tamoxifen in the treatment of the breast cancer they have introduced. Followed by Ecosoc 10, which is introduction of sentinel lymph node biopsy in the early breast cancer has been introduced. Later on, as we go, CalGB 943 have said if endocrine therapy itself is sufficient for as an adjuvant treatment for more than 70-year-old female. NACT 32 has and this Ecosoc 11, both are sentinel lymph node trials, which we will discuss in further slides. The Almanac and Amorous trial, these are the trials we can avoid axillary lymph node dissection in order to address axilla. And SNFNAC and Sentinel trial are the trials which describe about post NACT setting we can do sentinel lymph node biopsy or not. So ideal line should be there, minimum effective treatment we have to decide. We should not compromise with the treatment, and we should not go do over treatment also. So what is that ideal line? So there is many trials which are showing proper treatment. So de-escalation of the treatment is going on, and there are many strategies of de-escalation. That is hormone receptor positive and HER2 negative breast cancer, we can shorten the duration of endocrine therapy if possible. HER2 positive breast cancer, trastuzumab duration can be shortened or not. Avoidance of unnecessary axillary lymph node dissection in the selected early stage cancers. There are many radiation techniques has been implemented in our modern era to decrease the period of time and to decrease the period also. There is hypofractionation and accelerated partial breast irradiation. An oncotype DX and memaprint type of test has been introduced in our setting so that chemotherapy can be avoided in the less who has less likelihood of recurrence in the future life. So these are the landmark trials which we were reading from our general surgery days to compare the MRM versus BCS. And all of these trials, as we can see, NACT-06 is one of the landmark trial which have compared the lumpectomy versus mastectomy, and survival analysis they have seen it is equivalent and comparable to the mastectomy. The NACP06 question was there, is lumpectomy with or without RT is effective as total mastectomy? So we can see in this trial, lumpectomy only if have been done, only 39.2% recurrence is there. But if RT is introduced, then it becomes 14.3. Lumpectomy followed by RT is a good option which we can select. And now NCCN guidelines were updated, which has introduced that BCT followed by RT can be choose as a method of choice for early breast cancer. So this is my article which has been titled as de-escalation of surgery in T3 T4 breast cancer patients after neoadjuvant therapy, predictors of breast conservative comparison of long-term oncological outcomes with mastectomy. As we already seen, in early breast cancer with clinically node negative, there is no doubt we can go for BCS, but still after post NACT setting we can go for BCS or not. There are some controversies and there are no randomized control trial in this study. So this is still a controversial point. That's why we are discussing this paper. This is a retrospective study published in 16th March 2024, and this is a breast unit done in Italy. They have collected data from 2009 to April 2020, and they have discussed surgical outcomes and long-term oncological outcomes were compared between two arms, BCN and mastectomy group. So what is the introduction of neoadjuvant therapy? What neoadjuvant therapy do for the patient? It transforms inoperables to operable ones. It facilitates us to evaluate the in vivo tumor response, and it can prognosticate the patient, which in link to the long-term oncological outcomes. So successful tumor reduction of neoadjuvant therapy can minimize the treatment. Axillary lymph node dissection and BCS can be done, but still a surgical choice between the BCS mastectomy still remains complex and multifaceted. What is the aim of the study? To evaluate the difference between two surgical groups, that is BCS and mastectomy, to identify the predictors of breast conservation in CT3T4 tumors, and to compare the long-term outcomes between BCS and mastectomy. Study design, it is a retrospective study and they have collected patient data from their databases. Preoperative assessment, bilateral mammography, ultrasound, MRI and PET scan, not for every patient. We will see in future slides. Surgical and post-operative treatments they have evaluated and outcomes they have assessed. What was the inclusion criteria? CT3 T4 tumors, neoadjuvant therapy before surgery, all patients who have given in their own institute, specifically selected patients of group of oligometastatic patient with no comorbidities and a good performance status they have taken. They have excluded who has already did excisional biopsy outside, male patients, and prior breast cancer. Already they have some other cancer before that. Small T1 T2 tumors or unknown neoadjuvant therapy they have taken. Disease progression during neoadjuvant therapy and follow-up period is less than 50 months. They have excluded. For that they have uses for RECIST criteria, PET scan for the evaluation of post response assessment, and the YPT0 is the complete response of the primary tumor of surgical specimen, and PCR definition what they have taken, no detectable invasive and non-invasive cancer in both breast and nodal samples, and ALRED score they have used for estrogen and progesterone receptor status, and ASCO-CAP guidelines they have used for HER2 status. and every patient went to MDT for the decision patient should receive NAT or not. And analysis has been done of descriptive on data on the patient, tumor characteristics, surgical intervention and follow-up. And to compare continuous variables, they have used t-test, and for categorical variable chi-square test has been used, and more than 2 categories Fisher and by Fisher exact test they have used. Univariate and multivariate analysis they have done, and they found it, they given a significant only when it is p-value 0.005. Definitions of the endpoints they have used: the disease-free survival and distance disease-free survival. In both, they have started from the surgery date to the first occurrence and first identification of distant mets. But for overall survival and the breast cancer specific survival, overall survival and breast cancer specific survival, they have used the time of treatment begins. Kaplan-Meier curve is used for the probabilities of the survival, and log-rank test used for the comparison of survival. So these are the patient characteristics. As we can see, they have taken 114 patients, and all of them went for breast and axillary ultrasound, but mammography was done in only 80% of the patients, and PET was done only 35% of the patient. And vascular invasion and PCR they have found in 41% of the patients, and 41 patient 36%, and PCR in only 20%. And as per this they in their most common HER2 positive were the most common 49-43%, and YPD0 they have achieved in 24 patients, and YPN0 they have achieved in 53% of the patients. And anthracycline plus taxane with taxanes are the most common NAT drug they have used, around 86%. And sentinel lymph node biopsy follow BCS they have done only in 37 patients, and 77 patients have underwent for mastectomy. And sentinel lymph node biopsy done in 37 patients only. So they have compared with the surgical groups, that is BCS and mastectomy, and have done univariate and multivariate analysis. In univariate analysis, we can see the size of pre-chemotherapy size is very important, play a significant role. As p-value is less than 0.005, and the T3 CT3 has also benefited from the BCS. So it is also playing an important role, the size of tumor before chemo. And vascular invasion and post NAT size of tumor after chemotherapy is also very important. And vascular invasion, as we can see in BCS patient only 8 patients have, and mastectomy have 33 patients who have vascular invasion, they went for mastectomy. After a median follow-up of 17 months, 43 patients they found a recurrence, that is 37.7%, in which local recurrence in 11 patients and distant recurrence in 19 patients, and both recurrence in 13 patients. And total deaths what they have found is 30 patients. Breast CA 24 patients died due to breast cancer, and 6 died due to other cause. And out of them 6 patients who died, they are in the BCS category, and 24 patients died in the mastectomy arm. Comparison of long-term oncological outcomes between these groups, we can see the near disease-free survival and distant disease-free survival all are more. 77.1% in BCS arm, and mastectomy arm is 69.9%, but in 10-year follow-up they are coming to equal. So these graphs also we can see in this graph also, in early period BCS this is blue line is above mastectomy, but in later it's merging with the mastectomy. but p-value is not significant for all of them and they are comparable. There are similar studies which are also retrospective studies. This study was done in China. In this 916 patients went out of them only 191 patients have underwent uh, BCS, and they predicted that higher education and smaller tumor size is more turn up into the breast conservative surgeries, and patient older than 50 years and larger tumors are not going. And according to this study, they have seen response to NAC appear to play a no role in the surgical decision, suggesting that the potential surgical benefits they are deciding beforehand only, which patient should go for BCS or which patient should not. Another study published in 2020, they have also compared, but contrary to other studies, in this patient 64.5% of the patient underwent BCS, but all of them had small tumors, and the patient who have received mastectomy, they are larger tumor, node positive and lobular cancer. Since the small already tumors are smaller, so we can see the stages is very less, so overall survival ultimately will be better in the BCS arm, as we can see in this graph, 95.3%, and disease 5-year disease free survival is 90.9% for the BCS arm. So patient selection is very important and a crucial, very crucial. Tumor biology, stage of the patient, patient age, comorbidities, all do play a role in the decision what surgery has to be given to the patient. And shared decision making, a patient and the healthcare provider has to talk very freely, and benefits, risk benefit discussions and everything has to be explained and decision should be taken. And what patient want in long-term survivalship, if patient need of patient has to conserve, patient wants to conserve breast, then we have to give option. What are the challenges in the balancing? We have to make a goal between the treatment burden and maintaining optimal outcome. Lack of long-term data on the efficacy and safety of de-escalation strategies is still lacking, and we have to address the concept of under treatment and the risk of recurrence. So finally I can conclude that the de-escalation of treatment in the breast cancer is a paradigm shift towards the personalized and less toxic therapies, and there is a collaboration, innovation and patient-centered care are essential for optimizing the treatment. And according to this study, what they have seen, the absence of vascular invasion and reduced tumor size post NAT and achieving YP0 are the important key predictors which can conclude that BCS can be done. Thank you for this paper.
Okay. Soumya, am I audible?
Yes, sir.
Yeah, this is Dr. Dev. So, the first paper you presented is on the post-neoadjuvant chemotherapy, breast conservation therapy. So, on what criteria you can say it is a landmark paper?
This is not a landmark paper, sir. This is a retrospective paper, but this is a recent paper. Main issue for this is that there is no RCTs for which we can conclude in post NACT we can provide BCS or not.
Are you sure there are no RCTs? Have you reviewed the literature?
Sir, I have reviewed, but I have not find. I'm not sure, sir.
Yeah, there are RCTs where they have compared BCS rates following neoadjuvant chemotherapy in large operable breast cancers. The most landmark paper is NACBP 18, and that is the first paper which has shown you can increase the BCS rates following neoadjuvant chemotherapy, especially in T3 patients. And we also have an EVO-RTC study which has shown that that is where the concept of NACT followed by BCT has started. Okay.
Okay.
So what are the problems of retrospective study? Challenges?
Retrospective study, data is also not properly available, sir, and no proper guidelines had been made which patient all patients should go for equal investigations and equal follow up, that is also not there. And
The most important problem with retrospective study,
level of evidence is less.
selection bias. Okay,
Yes,
what is selection bias?
because selection bias, patient who have small disease they are going for less aggressive treatment, and large disease, higher stage, they are going for MRM. So 1:1 ratio or randomization has not been done, so there is a selection bias, sir.
Yeah. So what level of evidence you consider retrospective studies?
uh,
Level 1, level 2, level 3,
2, sir.
2. Is there any other criteria when you consider retrospective study?
Any other criteria?
Yeah, number of patients.
No.
Okay, we'll move on to the next question.
Yes.
Are you happy with the protocols that have been used for treatment in the study,
Sir,
including
they have no any rigid protocols, but all patients who have they have assessed, they have done USG and axillary sampling, axillary USG and breast USG, but mammography was also not done in 80% of the
yeah,
patients.
yeah. So
And
that's
PET
going to be
scans.
very important because when you do the assessment after neoadjuvant chemotherapy, the imaging is extremely important apart from your clinical assessment. Should have a uniform imaging pre-chemotherapy, post-chemotherapy. If you are using a mammogram, we use a mammogram for assessment. If you are using a MRI, you will use a MRI for post-chemotherapy assessment. Okay. And the last question before I hand over to Dr. Rosina, why there is no difference in 10-year survival when the at 10 years point between the two groups?
Why? I don't know, sir.
Okay. Okay, Dr. Rosina, you can start, please. Thank you.
Thank you.
Thank you.
I was going to come to the same question. You said about bias, Saumyta. We talked about bias of the patients. So what was the bias that you see in this study?
Sir, ma'am, small tumors who were previously also where can BCS can be applied on them. Only that patients have underwent for BCS. But rest of the patient who were previously were larger in size and large tumors, they
It
underwent.
doesn't necessarily, okay, it doesn't necessarily say that patients who were suitable for BCS had BCS, but overall patients who had smaller tumors at presentation had BCS. Now, how does that relate to the 10-year outcome? What would you expect? See, try to understand bias. If you are getting smaller tumors, what would be the sort of instinctive thing you expect?
We expect that smaller stages have more overall
That
survival.
they might do better.
Huh.
Okay? Yes. But now what happened?
But in 10 years, they are finding the same result.
So interestingly, sorry, I have a bad cough. Interestingly, you put up a slide, didn't you, about how breast cancer treatment has evolved. No, you don't have to go back. Listen, you put how breast cancer treatment has evolved. Okay? Now, one of the underpinnings, what are the underpinnings of this evolution? At one time it was like radical and then supra radical type of mastectomies. And breast cancer has de escalated because of certain understanding of biology. What is the biology of breast cancer that has
So
allowed people to
previously, ma'am,
consider de escalation?
previously it was considered as a locally spreading diseases. Then followed by the Fisher
Okay?
concept came in the place. Then it said it's like a systemic disease. then then the Hellman theory has been evolved, which said RT, because RT was beneficial in the breast cancer. So both systemic and local, we have to address the disease to in order to make proper treatment.
Yes, so does that lead you to an answer of what happens at 10 years? What you said now is correct. What I want you to do is read the lines of the paper and try to understand why these patients may not do better at 10 years. Why the early patients may not do better at 10 years.
Because systemic disease.
Yes, exactly. Exactly. So in the long term, it is the systemic disease that is dictating the outcome rather than the size of presentation or the exact stage of presentation of the primary.
Thank you, ma'am.
Yes? Okay. So the other thing so this is a retrospective paper and you listed the conclusions. How do you think these conclusions help us as surgeons? What are the outcomes? What are the conclusions of the paper?
Conclusion, ma'am, we can BCS and mastectomy, both options should be considered while the treatment of
Okay.
the breast cancer in the post NACT setting.
But true, but there was one more. What are the indicators of patients who got BCS? What were the indicators? You did say it. Yes, okay,
low
here you are.
size of tumor and size of the tumor and education, ma'am.
Education. Yes, okay. Right. So how did the surgeons decide? The point of this kind of indicators should be that if the patient has something, that helps another surgeon to decide whether to choose between two treatments. So looking at this, how can it impact your treatment, what you offer to a patient today?
So according to ma'am, what we can see, we have to mark the tumor. If we post NSCT, if YPT0 we are seeing or a good response we are seeing, then we can offer BCS to that patient also. That patient.
Yes, we can offer BCS to that patient without having an inferior outcome. Okay, you have to bring the two things together. What happens to patients in the long term, and how do you help to decide? So if there's been a good response, or you think there may be even a complete response, that helps you to decide. You can offer BCS when you discuss it with patients. You can offer BCS without having an inferior oncological outcome in the long term.
Yes, ma'am.
Okay. Now, because this is a small paper, isn't it? How many patients were there?
Only 114.
100.
Okay. So a small paper like this, would you expect it to change your practice?
No, ma'am.
Okay, but why would you read such a paper?
Just recent paper, ma'am. That's why I have taken.
That's not because it's a recent paper. It's a good paper to read. Why would you choose to read a paper like this?
Because
There
in
are so
recent
many
scenario
more
we are
publications.
seeing such type of in such type of conditions in India also. Post NSCT patients are more, higher stage people are more, so we can take an idea how to implement in our
Yes.
setting.
So it is. I know it is a paper from a good center where they have analyzed a small. I'm sorry, where they've analyzed a small number of people with a specific clinical situation, and they have given you some guidance which may help you in your discussion with patients. Yes?
Yes, ma'am.
Okay, so it's important to read papers that add to the evidence because you may not get another RCT between BCS and mastectomy in the future. Each of these adds to a small specific group of patients where the information just gradually adds up.
Okay.
Shall we move to the next paper?
Yes, Dr. Rosina, I think we are halfway down the line. Dr. Soumya, I can start the second paper.
Yes, sir. So second paper is a review of paper which is showing the emerging role of indocyanine green as a sentinel lymph node tracer in the breast cancer. So it's also part of a de-escalation. Involvement of axillary lymph node is a crucial and prognostic factor for the local recurrence and overall survival. And ALND is a historical standard associated with many complications. What is axillary management de-escalation? We started from axillary clearance to axillary sampling, followed by sentinel lymph node biopsy. If sentinel lymph node biopsy is positive, then also we can avoid ALND or not. Targeted axillary dissection, axillary RT, and no axillary staging. Since my paper is belongs to the SNB, then I will be confined to SNB. What is sentinel lymph node? This is the first echelon node, is the sentinel lymph node. As we can see, we are injecting a dye and lymphatic mapping has been done. So what are the morbidities of sentinel lymph node? Pain, lymphedema, numbness, all of them is higher in axillary lymph node dissection as compared to sentinel lymph node biopsy. So there are trials which are saying the equivalence of sentinel lymph node biopsy with the ALND, Varanasi et al., Almanac and NSBP 32. Primary endpoints of them is the accuracy of Varanasi, morbidity of sentinel lymph nodes in Almanac, and NSBP 32 efficacy of sentinel lymph node biopsy. So according to the NSBP 32, they have divided the patients in the two groups, sentinel lymph node plus ALND to all patients, and sentinel lymph node followed by ALND if sentinel lymph node is positive. And in 8 years they have noticed that the disease-free survival and overall survival both is same for the patient, is comparable. So concluded the patient have good results if we perform only sentinel node biopsy of the patient who have node negative on. There are trials who have shown the dissection, axillary dissection is not required after positive SLNB. These are the trials of ESOSOC, ZOO11, ETRAM, IBCSG, AMROS and OTASOR. I won't be discussing all, but I will be discussing first ECOSOC ZOO11 trial, who has been published in 2005, and they have randomized, this is a RCT trial, who has divided 890 patients they have randomized, and primary endpoint was overall survival, disease-free survival, local regional control. In this also you can see the tumor size is only less than 2 and more than 2. It's very small size tumor and receptor positive tumors they have taken. Primary endpoint we can see the axillary node dissection, and secondary endpoint disease-free survival. 86.3 in sentinel node arm and axillary arm 83.6. So in limited metastatic breast cancer also SLND alone is sufficient, and this is a non-inferior strategy. So these are the three RCTs. So micrometastasis as defined, size of sentinel lymph node mets less than 0.2 to 2 mm and more than 2 mm is the macromets. So for micrometastasis, if we are finding, as per in IBC-SG trial, they have in two arms ALND and no axillary treatment. Disease-free survival 10-year outcome is same. But in AMROS trial, they have given RT, and they have found that there is no axillary recurrence after 10 years, but contralateral breast cancer incidence is more in RT arm, which is statistically significant also. Role of sentinel lymph node biopsy after NACT. There are three trials which we can see: ECOSOC ZOO71, Sentina and SNFNAC. In SNFNAC, they have done ISC for the immunohistochemistry for the evaluation of sentinel node. But to decrease the false negative rate, minimum lymph node should be retrieved equal to 3 or more than 3. So these are the results of this study. that to decrease false negative rate for the post NACT setting, we should use dual dye, or 3 or more lymph nodes should be retrieved, and HE histopath examination to be done. So these all things we have concluded already. I have said false negative rate, to reduce false negative rate, dual tracer, more than 3 lymph nodes should be retrieved. And another important point, in post NACT setting, we have to mark good clinical examination should be done, and we have to mark USG guided marking should be done, and clipped lymph nodes should be removed at the time of sentinel lymph node biopsy, and both rest of the points I have already mentioned. So all these trials, since very long time we are research of the what lymphatic mapping and what we are doing, sentinel lymph node biopsy, LND. So this is an introduction of lymphatic mapping. First article Guglielmo has provided in 1994 for the blue dye mapping. Later on, radio label colloids has been instilled. And what current NCCN guidelines says about this, there is no palpable lymph node or clinically node negative, then we can go for sentinel node map excision. If sentinel lymph node is not identified, then ALND have to be done. But if sentinel lymph node coming negative, then axillary surgery should be avoided. It is category 1 evidence. Clinically suspicious and palpable node, significantly axillary lymph node is there, and the preoperative systemic therapy we have to mark by the USG guided FNAC and core biopsy. If FNA comes negative, then we have to follow above thing. But if FNAC's biopsy is positive, then preoperative chemotherapy we should give. In post NACT, if clinical node is still present, then we have to do LND. There is no other option. But if node positive convert into node negative, then SLNB can be considered as category 2B evidence. And if sentinel lymph node is coming positive, either we are doing BCR or mastectomy, doesn't matter. But T1, T2, N0, no preoperative chemotherapy, 1 or 2 positive sentinel lymph nodes, and whole breast RT is planned. If all factors are present, then we can go, no axillary surgery is required. If one of them is not present, we should go for LND. So there are the traditional tracers, blue dye, radioisotopes and combinations, and other novel tracers, ICG, contrast enhanced ultrasound, and microbubble and supermagnetic iron oxide nanoparticles. So vital blue dyes we are using alone or with the radiocolloid. 3 available blue dyes in isosulfan blue, methylene blue, and patent blue. So 3 to 5 ml blue dyes were used around the tumor, and intradermal injections of the dye are avoided for prevent tattooing of the breast and dermal necrosis. And blue dye's advantages: cheaper, widely available, does not require pre-op preparation, no risk of radiation, less operative time compared to radio tracer. But disadvantages: allergic and anaphylactic reactions, blue discoloration of urine, and skin necrosis if injected intradermally can be there. And drawbacks of radio tracers: expensive, require nuclear medicine facility, radiation exposure to both and operating theater personnel, and there are many logistic issues in supply and discharge of the radioactive agents. To overcome drawbacks, and there was a survey of the axillary management practice survey, in which 112 setups, 45 have only doing axillary dissection for node negative early breast cancer. And why they are not doing? Because 21 of the have not don't have radioactive dye, 12 don't have frozen section, and lack of training. So to overcome this radioactive part, we need a new dye which we can handle easily. So disadvantage of traditional users led us to research a novel agent of intraoperative lymphatic mapping in the breast cancer. So introduction of ICG came into the picture. ICG is non-toxic albumin-bound liver metabolized fluorescent iodide dye, clinically used since 1950s but not in breast. Water soluble, relatively hydrophobic, tend to aggregate resulting in the reduced NIR emission. Aggregation cause quenching phenomena. This is the mechanism of action. It NIR bloodstream, when we are putting it in bloodstreams, fluorescent excitation by a laser beam of 820 nanometer of non-infrared radiation. So when IV injected, it bounds to plasma protein, but in for our sentinel lymph node biopsy, we are putting outside the blood vessel. It bounds the protein to the lymphatic channels and reaching a closest lymphatic within few minutes. Timeline of ICG. Since it is introduced in 1950, but in breast surgery we have started using from 2005 onwards. These are the uses of the ICG in the modern era in surgical oncology or in surgery. They visualize the vital intraop structures for perfusion, for tumor imaging, sentinel lymph node biopsy, and to see the microvascular circulation of free flaps and evaluation of lymphedema. So what are the uses in the breast surgery? Breast surgery, axillary reverse mapping and detection of sentinel lymph nodes, and flap perfusion after mastectomy, perfusion of free flaps in the breast reconstruction, do lymphatic interpositional transfer and vascular lymph vessel transfer in oncoplasty, lymphovenous anastomosis, lymphedema screening, and VLNT in to harvest secondary lymphedema, and localization of flap perforators and for patency of the vascular anastomosis. So these are the papers from 2005. We can see there are many papers are coming for evaluation of ICG in the role of ICG in sentinel lymph node biopsy. What we can see from this slide that how much amount to be given, where to be given, and proper doses and which solution to be used, it's not equivalent in any of the trial. So that's the issue. After so many trials in the ICG has been done, but it's not even came into the practical guidelines yet. What are the benefits of ICG? Real-time visualization of lymphatic pathway, increased number of lymph nodes retrieved, pre-skin incision we can do lymph node mapping, easy to prepare, handle and use, no skin tattooing, necrosis, ulceration, nuclear medicine department help we don't require.
Dr. Saumya,
Yes sir.
can you come to the current study?
Yes sir.
Yeah, because we are running short of time.
This is the updated review on the emerging role of ICG as a sentinel lymph node tracer. This published in 8 December 2023, and they have taken 38 relevant clinical studies and 10 meta-analysis. The studies using ICG and blue dye as a sentinel biopsy tracer, in these have taken 10 to 12 studies, but in all these studies we can see the identification rate of ICG plus blue dye is 100%, and identification of ICG is 99.2%, and blue dye is only 83%, and which is statistically significant also. In Wang et al., most of the studies has been done in China because they are not using radioactive colloids. ICG is 100% Wang et al., and in Yang et al., its identification rate of ICG plus blue dye is 98.5. In all of these studies, we can see the ICG when combined with blue dye has identification rate are more than 95%. So sentinel lymph node mapping in the breast cancer with the use of ICG is superior to the use of blue dye alone, but we have to remove more lymph nodes for getting a good identification rate, and combining ICG plus blue dye have excellent result, raising a question whether the ICG can replace radioisotope in the gold standard dual RI plus blue dye. Now they have compared the studies which have using ICG and radioactive iodine only, and in this Bargan et al. In different part of the world, and Bargan et al. Netherlands, they have said identification rate of ICG is 96.1% and of RI is only 86.7%. And in another study we can see identification rate of ICG plus RI is 98.7, and it's almost equal to the ICG 98%. But there is one RCT Zhang et al. In 2019. They also said identification rate of ICG plus RI is 98.3%, but only if RI is 93.8%. After seeing all these studies, we can see that no ICG alone cannot may hypothesize it cannot be used only as an optimal tracer alone for sentinel mapping in the breast cancer. Either it is combining with the RI or it is combining with the blue dye to give good results. These are the studies. Out of them, three of done in India also. In our setting, what we can see, the ICG plus blue dye identification rate is 97%, and identification of RI plus blue dye is 95%, but statistically not that significant. But Agrawal et al. Done in 2022 has published one paper in which identification rate of ICG plus blue dye is 98%, p value is equal to 0.04, and there are similar comparative studies in which ICG combined with RI giving good efficacy and good identification rate. So after these studies, what we can see that the ICG combined with blue dye or ICG combined with RI technique is non-inferior compared to the gold standard RI plus blue dye, but ICG alone cannot be used. And other issue is cost effectiveness. The ICG when given with RI, if cost of device is not included, then it is cost effective. If device cost is included, then 118 sentinel lymph node biopsy procedures to be done to manage the cost. ICG as a sentinel node biopsy tracer in the post NACT setting, as we can see the clip, NCCNs recommend to clipping of the nodes before going for NACT, and dual tracers should be used, and 3 lymph nodes should be retrieved. So targeted axillary dissection is recommended. These are the studies which I have already seen, but now I have focused on the result of since the number of patients of all these studies we can see is very less, and post NACT is 24 and 35 patients, but identification rate after post NACT setting of ICG is 100% and 98.3%. So it's a good identification rate, but we have when they are combined together, this in Thailand they have combined ICG plus blue dye plus RI in the post NACT setting, so they have got a false negative rate less than 10%. So according to the above mentioned evidences, in post NACT setting, all of three of them when combined can give more better results than dual dye technique. And in obese patient, so three of the studies which have been done, they are saying that BMI is significantly affecting the identification rate, that, and two of them are saying the ICG is effective regardless of BMI. So for only 5 studies we cannot decide कि ICG is effective in a BMI in a obese patient or not. More evidence required to decide that. and ICG as a sentinel node biopsy tracer in the clinical practice guidelines. So dual technetium 99 plus blue dye technique is long established and widely used in the gold standard technique for mapping the sentinel lymph node biopsy. America has not at all added sentinel lymph node biopsy ICG as a tracer, but in Asia and Europe they have included ICG. China, it has China, they have used dual ICG with methylene blue, and hybrid tracer they have formed a radioactive plus fluorescent molecule. And according to the NICE guidelines of England, dual technique and isotope blue dye is the standard, and ESMO guideline include dual dye plus blue dye but in combination with RI, not alone. Japan has supported the use of ICG as a safe alternative. So they have taken 10 meta-analysis they have studied in this paper, in which they what they have concluded that Wang et al. They have taken 11 studies and number of patients is 2000. ICG plus blue dye has significant higher detection rate, and similar other study which have concluded that significant ICG has higher detection rate and significantly higher lymph node yield also, and ICG is equivalent to RI regarding the sentinel lymph node identification and superior to blue dye. So, for reading of all these evidences, what we have concluded that the comparison between ICG and standard blue dye technique comparable in two meta-analysis and better in for another two meta-analysis, and finally ICG plus blue dye as well as ICG plus RI method can be used as a both effective methods of mapping alternative to the standard blue dye and radioactive iodine and blue dye technique. So these are the limitations of ICG. Cost effectiveness is the issue. Iodine is there, so contrast allergy can be there. Contamination of surgical field. Sir, I am moving towards conclusion.
Yes, please do.
Yeah, please. We have only 10 minutes for discussion.
Overall, it is still unclear why ICG seems to be superior, and identification rates regarding and false negative rates are compared to conventional tracers, and introduction of hybrid tracers can overcome the drawback of ICG, that depth of from the skin. USG guided radio tracers plus hybrid tracers ICG plus technetium M99 nanocolloid can be used in future. And conventional tracers have some disadvantages. To overcome that disadvantages, ICG has been introduced, and for future ICG can be a good option, but with a combination of blue dye or RI, but not alone. Thank you.
Okay, thank you, Saumya. So this is again your second landmark paper, very relevant to the field, because now sentinel node is standard of care. Techniques are evolving, and ICG is now more than 10 years of clinical use. So this is a systematic analysis. Why it is called a updated systematic review?
Updated system, because sir,
systematic review. If you see the title of the article,
yes, sir,
it is mentioned it is this updated systematic review. So what does it mean?
Updated systematic review, it contains both reviews and meta-analysis. Meta-analysis itself is a review.
Okay, you are confusing. You see, update, it's already there are existing systematic reviews and meta-analysis on ICG. You got it? You yourself have shown a number of systematic reviews on ICG. So when the large body of data accumulates after the publication of previous systematic reviews, then you can again, the validity of a next systematic review will be more, because including new studies. Got it? So can you tell me what is PRISMA?
Yes,
PRISMA
sir.
guidelines? Yes.
PRISMA guidelines are the guidelines which are to validate the systematic reviews what if somebody is doing, and if
What is PRISMA? What is PRISMA? Can
it's
you
a
tell me the
flow
full
chart
form?
guideline, sir.
No, what is the full form of PRISMA?
Full
It's
form.
called Preferred Reporting Items for Systematic Review and Meta-Analysis. PRISMA. Okay?
Yes, sir.
Yeah, you should be aware of that. And it has got a statement concept 27 checklist and 4-phase flow diagram. How to go for a systematic analysis. So all students must be familiar with the PRISMA guidelines. How these are formed. There are certain guidelines we need to. There is a checklist and there is a 4-phase flow diagram. Okay. So two more questions because we are running short of time. Then I will hand it over to Dr. Rosina. So what is the highlight of this study? Anything new that has been added to the existing literature?
Sir, they have combined all the literature, and they have said that if ICG is used with blue dye or radioactive dye in a combination, the ICG plus blue dye is more reasonable. It can be a option alternative option for standard blue dye plus radioactive colloid.
Okay, so it is non-inferior to a dual technique, which is a standard of care, which is RI plus blue dye is a standard of care. So adding ICG or substituting ICG to a blue dye or a radioiodine is going to be non-inferior. That's what the whole study says. So this has been proven in previous studies also. So this is only strengthening the existing evidence. All right.
Yes, sir.
So it is not going to create a new evidence. I think it is only strengthening existing evidence, which we already know that ICG is a good alternative. So the last point is you said cost effectiveness. So how do you think ICG will be cost effective? Because you said except for the capital expenditure of the machine, the dye is very cheap.
Sir, what in this paper they have mentioned, if they are using this ICG, then
No,
there is.
I'm not talking about the paper. I'm asking your view. So how it will be cost effective, ICG? How to make it cost effective?
How to make it cost effective?
So you raised a point. There are cost issues. Okay.
Yes.
For blue
Sir,
dye,
one
there are no costs
fluorescein
involved.
dye,
Okay. For
fluorescein
a
dye
blue
or.
dye, there are not. For a blue dye, there are no major costs involved. There is no equipment. For radioiodine, you need a nuclear medicine department and radioisotopes, which is very expensive. When it comes to ICG, the machine is the cost investment. But if you are working in a multi-specialty hospital where ICG can be used by various other specialties, okay?
Yes.
So it can be used in all other fields, including plastic, GI, all right?
Yes.
So then the cost will go down. The second is the volumes. If you do big volumes, you can bring down the cost of the procedure, all right? Okay.
Yes.
So just to summarize, this is, I would say, not a landmark article, but a good review, which has actually proven the fact which already we are aware that ICG is a good alternative to any of the dual techniques, and it is non-inferior to a combination technique. And you should be familiar with how a systematic review is done, a meta-analysis is done. All the students should be familiar with the PRISMA guidelines and how systematic reviews are carried out. Thank you. I will hand over to Dr. Rosina, please.
I think you've covered the important questions. As a surgeon, why do you think blue dye, as Dr. Deo just said, is easily available and it's very, very low cost? Why do you think an additional technique is required at all?
Sir, ma'am, minimum number of lymph nodes, usually lymph nodes not yield is not that great with blue dye. Most of the times.
Sorry, how many lymph nodes do you need? What do you mean by lymph node yield?
We are putting blue dye and sometimes we cannot see intra-op also, ma'am. Blue dye is not able.
Okay, why do you think that is? Due to
lymphatic blockade, due to tumor cells.
Anything else? What do these other techniques give you that blue dye does not? Other techniques meaning whether it's isotope or whether it's a fluorescent dye.
We can do
What do they give
lymphatic
you?
mapping, ma'am, with
Yes.
lymphatic mapping
Yes.
in colloid.
So what do you mean by lymphatic mapping?
Means we have, from where we injected, it will show us the path. In spite of being we
Yes.
are not able to see the node in that, but we can able to see where it ends.
Okay,
we
so
can
what is the
judge.
advantage of adding these techniques to blue dye? Just rephrase what you said. What is the advantage of adding one of these two techniques to blue dye?
So in case we are not able to see that lymph node, but this mapping can help us where it is stopped, and there we can search for the node.
Yes, so it can give you an idea of the location of the node. When you're using blue dye alone, you may have to give a big incision because you don't know where the channel is going to be. Whereas if you're using one of these techniques, you can localize where the node is expected to be and you make a small incision. So as a surgeon, it gives you a roadmap which blue dye alone does not give.
Okay, I think Dave and Fusina, can you open Q&A and chat box? There are a couple of questions. Maybe we can answer that.
Yeah, I think most of the we've already answered as we went along.
Yeah. Okay. Yeah. Okay, then I think.
The one that has not been answered is this Swiss cheese response to NACT. See, if there is a Swiss cheese response, you must be very careful about your clinical findings. And clinically, if there is a sort of an ill-defined thickening or lump in the area, that very often will correspond with a Swiss cheese appearance on the mammogram, when you excise or on the mammogram, a Swiss cheese response to the NACT. So don't think that the mammo or the MRI alone will give you the answer. You're going to examine every patient properly post NACT and be careful about subtle residual changes in the breast, which do give you an